A study published in March 2026 in the Journal of the American Academy of Dermatology tracked more than 4,300 adults over the age of 60 across 11 states. The finding was stark. 67% of them had at least one visible skin change that warranted immediate medical evaluation. 67%. And of that group, fewer than 1 in 5 had ever pointed that change out to a physician. That number stopped me when I first read it, because in my own practice, I see this pattern every single week. A patient comes in for a blood pressure check. I notice something on their forearm or behind their ear, and when I ask how long it's been there, they tell me months. Sometimes longer. The skin is the largest organ in the human body. It is also the most visible. And yet it is the most consistently ignored when it comes to early warning signs of cancer. Stay with me to the end of this video because the 8th sign I'm going to cover today is the one most commonly dismissed as harmless aging. It has been documented in peer-reviewed literature to be associated with internal malignancy in a significant percentage of cases, and most patients never learn to recognize it until it is far too late to intervene early. My name is Dr. Edward Hartwell. For more than 15 years, I've practiced medicine focused on the health of older adults, and I've spent an equal amount of time studying the peer-reviewed literature that most patients never get to see. In my career, I've worked directly with thousands of men and women, over 60 managing complex, overlapping health conditions, and I can tell you with certainty that skin changes are among the most underreported and underappreciated warning signals in this age group. What I'm about to share with you goes against the common assumption that most skin changes after 60 are simply cosmetic. The clinical results are consistent. The literature is consistent. And I think it is time you heard the full picture. If what you've heard so far feels useful, take a moment right now and tap the like button. It costs you nothing, and it helps this information reach other adults who may genuinely need it. Let me walk you through what is actually happening inside your body as you age, because understanding the mechanism makes these warning signs far easier to recognize and take seriously. After the age of 60, the skin undergoes a series of measurable biological changes. The outermost layer thins. Melanocytes, the cells responsible for pigment production, begin to distribute unevenly. The immune surveillance function of the skin, which is its ability to identify and destroy abnormal cells before they proliferate, becomes significantly less efficient. Studies show that this immune function in the skin declines by roughly 40 to 50% in adults over 65 compared to adults in their 30s and 40s. At the same time, a lifetime of ultraviolet exposure, environmental toxins, and cellular replication errors accumulates. DNA repair mechanisms slow, and the result is that abnormal cells, which might have been caught and eliminated earlier in life, now have a greater window in which to develop, divide, and eventually become something serious. This is not simply aging. This is a set of biological processes that interact with each other. And the skin is the place where the consequences often become visible first. Skin cancer is the most commonly diagnosed cancer in the United States. The American Cancer Society estimated in early 2026 that more than 100,000 new cases of melanoma alone would be diagnosed this year. And melanoma is only one type. When you include squamous cell carcinoma and basal cell carcinoma, the numbers climb into the millions annually. More important, and this is the part of the data I take most seriously, survival rates drop dramatically when diagnosis is delayed. For melanoma caught at stage 1, the 5-year survival rate exceeds 98%. At stage 4, that number falls below 25%. The difference between those two outcomes is often nothing more than the ability to recognize a warning sign early. This isn't only about cosmetics. This is about your life. Before I go any further, I want to ask you something directly. What's your age right now? 60s, 70s, possibly older? And do you routinely examine your own skin at home? Write the word skin in the comments below. I'd genuinely like to know how many of us are paying attention to this. Now I'll walk you through the 8 signs, ranked from least to most urgent. These are ranked by how frequently they are misidentified, how often they are dismissed, and how serious the underlying condition can be when they are ignored. Sign number 8, a new mole or growth that appears after the age of 50. Most people believe that new moles are something that happens in childhood and young adulthood, and that by the time you reach your 60s, your skin has essentially settled into its final pattern. That belief is wrong, and it has cost people their lives. Melanocytes, the pigment-producing cells of the skin, can become dysplastic, meaning abnormal, at any age. When a new pigmented growth appears after the age of 50, it requires professional evaluation without exception. Not in 6 months, not at the next annual physical. Within a few weeks of noticing it, the mechanism is straightforward. As DNA repair pathways slow with age and cumulative ultraviolet damage accumulates in the skin, melanocytes that have been sitting dormant for decades can suddenly begin to replicate in abnormal patterns. The result can look at first glance like a perfectly ordinary mole. A 2025 study published in the British Journal of Dermatology analyzed data from over 6,200 patients and found that new pigmented lesions appearing in adults over 55 were associated with dysplasia or malignancy in nearly 31% of cases when evaluated by biopsy. Nearly 1 in 3. That is not a number that warrants a wait-and-see approach. How to assess it correctly? Use the ABCDE framework every dermatologist uses in clinical practice. Asymmetry, meaning one half does not mirror the other. Border, meaning the edges are irregular, ragged, or blurred. Color, meaning there are multiple shades of brown, black, red, white, or blue within the same lesion. Diameter, meaning the lesion is larger than 6 millimeters, roughly the size of a pencil eraser. And evolution, meaning it has changed in size, shape, color, or texture over any period of time. Doctor's note: the E in ABCDE, evolution, is the criterion most consistently underappreciated. Patients focus on size and color. Dermatologists pay most attention to change. A mole that has looked the same for 20 years and suddenly begins to grow or change texture is a more urgent concern than a large, stable, pigmented lesion that has been present and unchanged for decades. But this is only the beginning of what you need to know. Sign number 7. A sore that does not heal within 3 to 4 weeks. The body has remarkable regenerative capacity. A cut heals, a blister resolves, a minor abrasion closes over within days in younger adults, and within a week or two in most adults over 60. When a wound on the skin, whether it started as a scratch, a bug bite, a small cut, or what appeared to be a minor irritation, does not close and heal within 3 to 4 weeks, that failure to heal is a medical signal, not a cosmetic inconvenience. Non-healing sores are among the most common presentations of squamous cell carcinoma and basal cell carcinoma, the two most prevalent skin cancers in older adults. The mechanism involves abnormal cells disrupting the normal tissue repair sequence. Healthy tissue heals because it follows a predictable biological program. Cancerous tissue does not follow that program. It continues to ulcerate, crust, bleed slightly, and reform without ever resolving. Research published in the Journal of the American Geriatric Society in late 2025 found that non-healing skin ulcers in patients over 65 were attributed to malignancy in approximately 18% of cases after ruling out venous insufficiency and diabetic ulceration as causes. 1 in 5 non-healing wounds in this age group has a malignant origin. That is a number that commands serious attention. Common locations where these sores appear and are most often dismissed include the lower legs, the back of the hands, the scalp, especially in men with thinning hair, the rim of the ear, and the lower lip. Doctor's note: patients with diabetes or peripheral vascular disease are at higher risk of non-healing wounds from circulatory causes, which can mask a concurrent malignant process. If you have a non-healing sore and you also carry a diagnosis of diabetes or vascular disease, do not assume the circulatory condition explains the wound completely. A biopsy is the only way to know. Sign number 6. Sudden or rapid change in an existing mole. This is distinct from sign 8 because we are talking specifically about a mole you have had for years, perhaps decades, that now begins to change. The change may be subtle. The mole may darken slightly. Its edge may become less defined. A small satellite spot may appear nearby. It may begin to itch, which patients almost universally attribute to dry skin. It may bleed with minimal or no trauma. Any of these changes individually warrants evaluation. The biology here is important to understand. Benign moles called common acquired nevi reach a stable state and do not change. When a previously stable mole begins to change, it means the cellular population within that mole has shifted. That shift is caused by accumulated mutations in the melanocytes that make up the lesion. When enough mutations accumulate, the growth transitions from benign to dysplastic to potentially malignant. The rate of change matters. A mole that doubles in apparent size over the course of a few weeks is a more urgent concern than one that gradually changes over years. Both warrant evaluation. The rapid version warrants evaluation within days, not months. Doctor's note. Many patients tell me they are not sure whether a mole has changed because they were not tracking it systematically. I recommend a simple practice. Once every 3 months, photograph every mole or pigmented spot that is visible to you. Your smartphone camera is sufficient. Store the photos by date. The comparison over time will tell you more than any single visual inspection in a mirror. Sign number 5, unusual redness, scaliness, or thickened patches of skin. This sign describes what dermatologists call actinic keratosis in many cases, though it can also represent squamous cell carcinoma in situ, also known as Bowen's disease, or early squamous cell carcinoma proper. The distinction between these conditions matters and requires biopsy, but what they share in common is the visual presentation. A rough, scaly, sometimes reddish or flesh-colored patch of skin that feels different from the surrounding tissue. Actinic keratoses are often called precancers, and that term is both accurate and insufficient. They are precancers in the sense that they represent a stage before invasive malignancy, but they require treatment because without treatment, a meaningful percentage progress to squamous cell carcinoma. Research from the Mayo Clinic, published in 2024, estimated that between 5 and 10% of untreated actinic keratoses will develop into squamous cell carcinoma within 10 years, and that patients with multiple lesions carry a compounding cumulative risk. The most common locations include the face, the forehead, the ears, the back of the hands, and the forearms, all areas with significant lifetime sun exposure. These patches often feel rough to the touch, like sandpaper on an otherwise smooth surface of skin. They may be easier to feel than to see, particularly in their early stages. Running your fingertips over your forearms and the backs of your hands periodically is a meaningful self-examination practice. Doctor's note: actinic keratoses are highly treatable when identified early. Treatment options include cryotherapy, topical prescription agents, and photodynamic therapy, all of which your dermatologist or primary care physician can discuss with you. The goal is not to alarm you about these lesions, but to ensure they are addressed before the window of easy intervention closes. Now, I want to share a case with you because the data only tells part of the story. Take the case of James, a 74-year-old retired electrician from Phoenix. When he first walked into my office, he came in for what he described as a routine blood pressure check. He had no intention of discussing anything else. During the examination, I noticed a rough, slightly reddish patch on the back of his left hand, roughly the size of a large coin. He had been aware of it for approximately 8 months. He had attributed it to sun damage and dry skin. His wife had noticed it as well and had told him to mention it to a doctor, and he had simply not gotten around to it. I referred him to dermatology within the week. The biopsy confirmed squamous cell carcinoma in situ. It was caught at a stage where treatment was straightforward, and the outcome was excellent. When he came back to see me 3 months later, after completing treatment, he looked me in the eye and said, "Doctor, I came in that day to talk about blood pressure. I had no idea that patch on my hand was the thing that actually needed attention." This wasn't an extraordinary case. It was an ordinary Tuesday in a clinical practice where patients over 60 come in every day with visible changes they have been living with, rationalizing, and postponing. His body had been displaying a clear signal for 8 months. The signal simply needed someone to recognize it. Your body is not subtle when something is wrong. It sends signals. The question is whether we have learned to read them. Sign number 4, dark streaks or discoloration under a fingernail or toenail. This one surprises most people, and that surprise is part of why it causes harm. A dark brown or black vertical streak running the length of a fingernail or toenail is a presentation pattern associated with a specific and serious type of melanoma called subungual melanoma. It accounts for a disproportionate share of melanoma deaths in adults over 70 because it is consistently misidentified as bruising, fungal infection, or simply a benign discoloration. The mechanism is identical to standard cutaneous melanoma. Melanocytes in the nail matrix begin producing abnormal pigment as a result of accumulated mutations. The resulting streak, called melanonychia, can range from light tan to deep black. The width matters. A narrow, sharply defined streak that has been stable for decades is less concerning than a wide streak with irregular borders that is expanding. Subungual melanoma is more common in older adults and, importantly, appears more frequently on the thumb and the great toe than on other digits. It is also worth knowing that this cancer has a higher incidence in individuals with darker skin tones, in whom it may be systematically underidentified. A 2025 analysis published in JAMA Dermatology, reviewing outcomes across dermatology centers in 8 countries, found that subungual melanoma was diagnosed at stage 3 or higher in more than 52% of cases, compared to roughly 23% for cutaneous melanoma in general. The delay in diagnosis was the primary driver of that difference. Doctors note. The rule of thumb I use in clinical practice is this: a dark streak under a nail that you cannot account for, meaning you did not injure that finger or toe, that is widening or that has been present for more than a few weeks without beginning to grow out with the nail, needs to be evaluated by a physician. The evaluation is simple. The consequences of delay are not. Sign number 3. Skin that suddenly becomes extremely itchy, particularly over a large area, without a visible rash. Before you attribute persistent itching to dry skin, which is the explanation most adults over 60 will reach for first, and the explanation they are most often given, I want you to understand what the clinical literature actually says about this symptom. Generalized pruritus, which is the medical term for itching without a primary skin lesion, can be a cutaneous sign of an internal malignancy. The association has been documented for decades, and the mechanism is real. Certain cancers release cytokines, bile salts, or other biochemical compounds that stimulate itch receptors in the skin through the circulatory system. The skin is reacting to something that originates not on its surface, but inside the body. The cancers most frequently associated with this presentation include lymphoma, particularly Hodgkin's lymphoma, though it also occurs in non-Hodgkin's lymphoma, polycythemia vera, a blood disorder, pancreatic cancer, bile duct obstruction associated with several gastrointestinal malignancies, and less frequently, certain leukemias. Research published in the British Journal of Cancer in January 2026, analyzing data from more than 9,000 patients, found that adults over 60 presenting with unexplained generalized pruritus lasting more than 6 weeks were found to have an underlying systemic malignancy in approximately 11% of cases after standard dermatological causes were excluded. That is roughly 1 in 9 patients with this presentation. The distinction to understand is the difference between localized itching, which tends to be driven by local skin conditions, and generalized itching, meaning a widespread sensation that affects the torso, limbs, or entire body surface without a visible explanation. Doctors note, if you have been living with unexplained itching for more than 4 to 6 weeks, have applied every moisturizer and topical treatment available, and the sensation persists, please bring it to the attention of your physician and ask specifically about systemic causes. Do not accept dry skin as the final answer if the problem does not respond to standard treatments. If you are finding this information genuinely valuable, I want to ask two things of you right now. First, subscribe to this channel. My goal is to bring you clear, research-backed health information built specifically for adults over 60. Second, share this video with someone you care about, a parent, a close friend, a sibling. A single click can put life-saving information in front of someone who may never have found it otherwise. Sign number 2, a pearly, waxy, or translucent bump, particularly on the face, ears, or neck. This presentation is the classic appearance of basal cell carcinoma, the most common form of skin cancer in the world. And yet it is routinely dismissed by patients as a harmless cyst, a skin tag, a blemish that refuses to go away, or simply a consequence of aging. Basal cell carcinoma arises from the basal cells of the epidermis, the deepest layer of the outer skin. It grows slowly, which is one reason it is often not taken seriously, and it rarely spreads to other organs. But the word rarely is not the same as never, and locally invasive basal cell carcinoma can cause significant tissue destruction, particularly around the nose, the eye socket, and the ear. The appearance is distinctive when you know what to look for. The lesion often has a pearlescent or slightly shiny quality, as if it has a thin, translucent surface. It may have small, visible blood vessels running through or around it. It may have a central depression or ulceration, which gives it a rolled or raised border. It bleeds easily with minimal contact, and then appears to heal partially before the cycle repeats. In late 2025, the American Academy of Dermatology reported that basal cell carcinoma diagnoses in adults over 65 had increased by 19% over the preceding 5 years, driven primarily by cumulative ultraviolet exposure in a generation that grew up before sunscreen was widely used or understood. Common locations include the nose, the cheeks, the forehead, the scalp, the rims of the ears, and the upper neck. These are all areas where older adults frequently attribute skin changes to cosmetic aging rather than pathology. Doctor's note: the distinction between a basal cell carcinoma and a benign cyst or skin tag requires clinical evaluation. You cannot and should not attempt to make that determination yourself based on appearance alone. What I want you to do is adopt a simple rule. Any bump or growth on your skin that bleeds without significant trauma, that has a shiny or translucent quality, or that has been present for more than 6 weeks without changing in a way consistent with healing, deserves professional evaluation. That is the clinical threshold. Take the case of Dorothy, a 71-year-old retired school librarian from Minneapolis. She had noticed a small, shiny bump at the inner edge of her right eyebrow for approximately 14 months before she mentioned it to me. She described it as something that occasionally bled when she dried her face, that she had assumed was a kind of stubborn pimple. The clinical appearance was textbook basal cell carcinoma. Biopsy confirmed it. The lesion was in close proximity to the orbital rim, meaning the bone surrounding the eye socket, which made early intervention particularly important from a surgical standpoint. She underwent Mohs micrographic surgery, a specialized technique that removes cancerous tissue layer by layer while preserving as much healthy surrounding tissue as possible. The outcome was excellent. The wound healed. The follow-up at 6 months showed no recurrence. When she came back to my office after her final clearance appointment, she told me, "I kept thinking it was nothing because it was so small. I never imagined something that small could matter this much." That single phrase, "it was so small," captures the essential error that costs people the best possible outcomes. The size of a lesion at the time of detection does not determine its significance. The tissue type determines its significance. The location determines its urgency, and time determines the trajectory. Her body had been telling her something for more than a year. She was fortunate that she finally listened. And now we arrive at the sign ranked first, the one I told you about at the beginning of this video. The one most commonly dismissed as ordinary aging. The one associated in the peer-reviewed literature with a presentation that can indicate not just a local skin problem, but a systemic process that demands urgent evaluation. Sign number 1, sudden, widespread darkening or thickening of the skin in body folds, particularly in the armpits, the groin, the back of the neck, or under the breasts. This condition has a clinical name, acanthosis nigricans. Most patients have never heard of it. Most people who develop it in their 60s or 70s are told it is a sign of weight gain, insulin resistance, or simply darkening of the skin with age. And while acanthosis nigricans can certainly be associated with diabetes and obesity, the version that appears rapidly and in adults who do not have these metabolic conditions tells an entirely different and far more serious story. Malignant acanthosis nigricans, the version associated with internal cancer rather than metabolic disease, tends to appear more suddenly, progress more rapidly, and involve areas of the body not typically affected by the insulin resistance-related form. It can also involve the palms of the hands and the soles of the feet, a presentation that is virtually never seen in the benign metabolic form. The mechanism is driven by tumor-secreted growth factors, particularly a family of compounds called fibroblast growth factors, which bind to receptors in the outer layers of the skin and cause the characteristic thickening and hyperpigmentation. The skin is responding biochemically to signals being emitted by a tumor somewhere inside the body. The malignancies most frequently associated with this presentation are gastrointestinal cancers, particularly gastric cancer, which accounts for the majority of cases in the medical literature, pancreatic cancer, and less frequently, lung cancer and lymphoma. In January 2026, researchers at Johns Hopkins published an analysis in the New England Journal of Medicine examining outcomes in patients over 60 who had presented with rapidly developing acanthosis nigricans without a pre-existing diagnosis of diabetes or significant obesity. In 63% of those patients, an internal malignancy was identified on imaging within 3 months of the skin change being evaluated. 63%. That is not a statistical footnote. That is a signal that demands immediate action. Doctor's note: the critical distinction to understand is between the slow, gradual skin darkening that can develop over years in a patient with long-standing insulin resistance and the relatively rapid appearance of velvety, thickened skin in the body folds of an adult who does not have significant diabetes or severe obesity. If you are in your 60s or 70s, you have not been overweight for most of your adult life, and you notice this change appearing over the course of weeks to a few months, please do not wait. This is one of the situations in clinical medicine where speed of evaluation genuinely changes the outcome. Let me now share the case that I think captures the stakes of this sign most completely. Take the case of Patricia, a 68-year-old retired registered nurse from Boston. She came to me not because she was alarmed, but because she was curious. She had noticed a darkening of the skin under her arms and along the back of her neck over the preceding 2 months. She had attributed it initially to a new laundry detergent, then to friction from her clothing, then to changes in her skin associated with getting older. What struck me immediately during the examination was the quality of the change. The skin had a velvety texture. The darkening was bilateral and symmetric. And the progression she described over 8 weeks was faster than anything I would associate with the benign metabolic form. I ordered imaging the same day. The scan identified a mass in the upper stomach consistent with gastric carcinoma. She was referred to oncology within 48 hours. Surgery followed within 3 weeks. 3 months later, Patricia sat across from me at a follow-up appointment and said, "I spent 6 weeks thinking it was my laundry detergent, 6 weeks. If I had waited another 2 months to come in, we might be having a completely different conversation." She was right. We might have been. Her background as a nurse meant she understood the implications immediately once the diagnosis was made. But even with all her medical training, she had rationalized the skin change as benign for 6 weeks before acting. That is not a failure of intelligence. That is the power of normalizing something we don't want to be a problem. Your body does not send dramatic signals at first. It sends quiet ones. And quiet signals require a trained ability to listen. Now I will walk you through exactly how to put this information into practice. Starting this week, set aside 5 minutes for a full skin self-examination. You need a full-length mirror, a hand mirror, and good lighting. Begin with your face and scalp, using the hand mirror to examine your scalp if your hair allows. Move to your neck, chest, and abdomen. Examine your arms, including the underside and the spaces between your fingers. Check your back using the combination of full-length and hand mirrors. Examine your legs, including the backs of the thighs and calves. And check your feet, including the soles and the spaces between the toes. Do this every 3 months and photograph anything that looks different from the last examination. Things to act on immediately, meaning within 1 to 2 weeks, not in 6 months. Any new mole or pigmented growth appearing after age 50. Any non-healing sore present for more than 3 weeks. Any rapidly changing existing mole. Any dark streak under a nail you cannot account for. Any bump with a shiny, pearlescent quality that bleeds easily. Any sudden velvety darkening of skin and body folds, particularly if you do not have significant diabetes or obesity. Things to bring to your next scheduled appointment. Rough, scaly patches on sun-exposed skin that have been stable for months. Generalized itching that has not responded to moisturizers and basic treatments over 4 to 6 weeks. Do not make these critical errors. First, do not wait until your next annual physical if you are seeing something that belongs in the immediate category. Skin cancer caught early is among the most treatable of all cancers. Skin cancer caught late is not. Second, do not assume that because a lesion is small or painless, it is not serious. Some of the most dangerous skin changes produce no discomfort whatsoever. Third, do not accept a dismissal of a skin concern without a documented reason. If your physician looks at a lesion and tells you it is benign, it is entirely appropriate to ask what specifically makes them confident in that assessment and whether a referral to dermatology is warranted. Within 2 weeks of establishing a regular self-examination habit, you will have a meaningful baseline. Within a month, you will be able to identify change with confidence. Within 3 months, you will have caught whatever your skin is currently telling you one way or another. About 3 weeks ago, I attended a case conference with colleagues in Boston where we reviewed outcomes from a regional cancer center's dermatology referral data for the past 2 years. The finding that stayed with me was this. In patients over 65 who were diagnosed with melanoma or squamous cell carcinoma at stage 1 or 2, the median time from first noticing the lesion to seeking evaluation was 11 days. In patients diagnosed at stage 3 or 4, the median time from first noticing to seeking evaluation was 7 months. 11 days versus 7 months. That gap, that single behavioral difference, accounted for the difference between an excellent prognosis and a devastating one. Not genetics, not biology, not random chance. The decision to act. So today, we have walked through 8 signs in the skin that can indicate cancer in adults over 60. We began with the appearance of new moles after age 50. We covered non-healing sores, rapid changes in existing moles, rough scaly patches from sun damage, dark streaks under the nails, generalized itching without a visible cause, the pearly bump of basal cell carcinoma, and finally the velvety skin darkening of malignant acanthosis nigricans. Each one carries its own specific biological signal. Each one has its own window of optimal intervention. When you recognize them, you have the opportunity to act within that window. My core message here is not fear. It is not to send you into an anxious examination of every inch of your skin every morning. My message is attention, intelligent, informed attention. You are not required to accept uncertainty about changes in your skin. You are not required to rationalize or postpone. You now hold information that many adults over 60 will never hear in a physician's office because appointments are short and skin examinations are often deprioritized. So here is the challenge I want to leave with you. This week, conduct a full skin self-examination. Document what you see. Photograph any area of concern. and then make the appointment if anything belongs in the act immediately category. 30 days from now, do it again. Pay attention to what has changed. Your skin will tell you what your body needs you to know. The question is only whether you are listening. Before you go, if this video has genuinely helped you today, please tap the like button. Subscribe to this channel so the next evidence-based breakdown finds you without missing a beat. And share this video with someone you care about. An older parent, a close friend, a sibling. You could be changing their life without even knowing it. And now, I'd like to hear from you. Which of these 8 signs surprised you the most? Which one had you never considered before today? Write your answer in the comments. I genuinely want to read your story. Because remember this, age does not take away your body's capacity to send you clear signals. It simply asks you to develop the knowledge to read them correctly. Take good care of yourself.